briefly walk through the project objectives and just some discussion prompts. And we have the email here. We will announce it again at the end of the meeting if you would like to send us comments in writing. Go ahead and move to the next slide. Just to kind of level set, the purpose of the evaluation is to really look at developing a system for establishing and maintaining rates that are sufficient to sustain providers and ensure main care members have access to high quality service. It's also to evaluate the rates and rate setting system, develop a plan for how to move forward with the creation of a comprehensive, streamlined, and coherent system for the future. To sort of look at us on the timeline, we did provider listening sessions in October and member listening sessions in November, and now we're here in the second grouping of provider listening sessions. In November, we released the cataloging and benchmarking report. And then we are having these meetings really to get more context around that information so that when we're looking at the interim and final report and the findings for those sections, we have an idea of, we have more information and more context other than just the data. If you could go to the next, thank you. So the meeting structure for today, our role is to really ensure that participants keep their comments within a fixed time frame. This is a big meeting, but what I'm going to hope is that everyone just respects each other and respects that other people are going to want to speak and keeps your comments to a reasonable length of time so that other people have an opportunity. If it gets really long, I'll probably wave at you and ask you to wrap it up so that other people can speak. Also to ensure that comments pertain to the topic under discussion and then record the meeting. Your role prior to commenting is to introduce yourself, your organization, and the services you provide. This helps us to associate your comments to the right services. And if someone says something you agree with, it's totally fine to say I agree with that person rather than repeating it. And then again, just respect each other in the meeting and give everyone an opportunity to be able to speak. Go ahead and move to the next slide. So the purpose of today's meeting is to get your feedback on the additional points you suggest for consideration regarding the rate comparison, and then to give feedback on how you feel the sufficiency of your current rates are and any issues related to the rates and their impact on access or sustainability. To that end, we put together a few discussion prompts. These are just to help you to frame feedback to us and think about some things that we're thinking about as well. Are there assumptions or costs that are critical to consider that may be unique to me that wouldn't be reflected in another state's rate? Are there differences in payment methodology, services that may explain some of the differences in certain rates that may not be evident by examining the fee schedule and service descriptions? And for this particular group, we also looked at provider requirements in order to be able to provide some comparative match with other states. Are there services where current rates contribute to access or quality issues, and do these issues then impact other parts of the service system? So those are just some discussion prompts for you for the things that we're also kind of thinking about. If everyone, I will start opening it up now. If you would like to speak, please click the raise hand button. If you can't find the button, like I said, if you click the participants tab, it should be on there. But if not, it's totally fine to chat at us and Jillian will unmute you.
Okay, first up I have Rebecca Emmons.
Good morning. Thank you for the opportunity to provide comment today. My name is Rebecca Emmons. I'm the Executive Director at Mobius, and I am a board member for MAXB, representing the Community and Work Support Services. I'll be providing comments on Section 21 and 29 T2021 DAHAB and Sections 21 and 29 H2023 Employment Supports. As a provider community, we look forward to providing OMS and the department with additional information and potentially opportunities for primary source data regarding our costs of providing these services. Regarding cost considerations, the cost driver of minimum wage is a consistent metric with variable values across all states, and it's concerning that it's not referenced as a benchmark. The inclusion of minimum wage as a wage floor for all Medicaid rates would be a practical assumption to make, And in a realistic world, the wage floor would be 125% of minimum wage and account for annual inflation through a cost of living adjustment. Other metrics that are state-specific include workers' compensation, unemployment contributions, and Maine being a very small insurance marketplace. The cost incurred by Maine providers with greater than 50 employees to provide competitive health insurance benefits is significant, and it directly impacts our ability to recruit and retain direct care workers. In the benchmark report, the rate of 846 is used to benchmark quarter-hour units of day-hab services. The current quarter-hour rate for this service is actually 653, with a medical add-on rate of 805. We're concerned as to the origin, or where did the number of 846 come from. Additionally, the calendar year 2019 Maine claims data for day-hab is listed as exactly the same as the supported employment rate. This isn't accurate, and we request there be additional review on the 846 rate that's used within the benchmark report. An additional cost metric would be the total cost of care. DHHS and OMS have referenced the total cost of care metric in the past. The inclusion of total cost of care per Maine HCBS member will be important to provide important context as to the level of care that we provide our HCBS members here in Maine. Regarding payment methodology, in Maine, transportation is included in our reimbursement rate. And for the comparison states, did the study determine if the cost of transportation was included, or is transportation carved out of the rate paid in other states? Maine discontinued supplementing day-hab services with state grant and contract funds in 2018. Beyond Medicaid, are there additional funding sources contributing to the provision of T2021 and H2023 services in the comparison states? The use of contract state grant funds directly contributes to the availability of services in respective states, and we have seen that the loss of those funds has contributed to a gap in service accessibility by Maine Care members. There are active Maine Care policy efforts to shift how day-hab and supported employment services are provided in Maine. These proposed changes are structural, with additions of payment modification for one-to-one, paired, or small group services, and contextual, seeking to distinguish between community and facility settings. Similarly, Maine Employment Support Services have structural modifiers, such as one-on-one and group work supports. The administrative burden to providing services with this level of definition and detail will be daunting, and payment methods should be either focused on the setting in which an individual receives the service or the ratio of staff to clients, not both. Referring back to cost assumptions, the monitoring and tracking of day-hab services will require additional personnel, documentation, and costs associated with continuous quality assurance. Regarding service models, structures, and the unique attributes of Maine-based services, Connecticut services are a mix of community-based private and state-run entities. Connecticut has state and privately run institutions. How many comparison states are using institutional care? Maine exclusively uses a community-based model of care. Based upon the Maine HCBS assessment conducted by Aconsis, our forms of institutions rarely exceed 6 residents. This community-based model costs more money, and it should. Maine is making the right investment in our HCBS members, particularly as it relates to community and work supports. And we fear that a comparison to states who employ institutional level of care for their waiver services members will directly impact the waiver service members' access to care. Maine strives to be a workforce state. However, from the community perspective, the opportunity to secure long-term work supports or employment supports has dwindled in the last 10 years. We strongly encourage the next phases of the rate review process to include a 10-year look back to assess the number of Maine Care members receiving H2023 services and the number of HCBS providers billing for this service. The decrease in providers of employment support services is directly tied to the service model for employment supports and an inadequate reimbursement rate. Thank you for the time to speak on behalf of Maxby and Mobius.
Thank you, Rebecca. Next up, I have Dennis Strout.
Yes, hello. My name is Dennis Strout, and I'm with an organization called Momentum, and I'm the executive director there, have been for 24 years. And there's going to be many points made today, and I wanted to make some that perhaps weren't made, but also consider some that perhaps will be made as well. So my first point is, or question is, I guess, is why you would want to reduce our funding revenue within community supports 21 and 29 sections. And the other question is, do you realize this is occurring? And so I'm speculating based on what I'm understanding and reading is that you may not realize that that's happening or would happen if these rates are implemented as they're proposed. And so my worry is and understanding is that our revenue would reduce. And so I don't think that's your intention, but it's based on the one-to-one, which is a vitally needed service within community support and is available now, but it's very challenging to get. And also 1-2 and 1-3. And one of the challenges with the 1-3 is that there's no average. And so not being able to average that proposes some real significant challenges in the day-to-day flexibilities when staff call out sick or clients are out or this is just lots of variables that I think maybe just folks don't understand that do occur. And then my last point is, was self-determination considered within the model that's been created? And some of you folks may be well-versed in self-determination. And also, was SUFU referenced at all as a means for information? SUFU is Speaking Up for Us of Maine, and they're a self-advocacy group, as many of you know. And so, were they referenced? So thank you for the time. I really appreciate your listening and having the session today. And I wish you well with working out all the details. Thank you.
Julia, I can jump in there. I just want to be very clear that this report in no way represents a proposal for any change to rates. It is simply meant to provide information on comparison rates for the services we currently provide. So it is a piece of information. It is imperfect information, which we've acknowledged, and thank Becca for pointing out some other areas we need to look into. But this is not a rate proposal. For any services, we will need to do a more in-depth rate assessment and rate review before determining any rate changes that were to happen. So I wanted to be very clear about that point. And then in terms of the question about SUFU, we did have a number of member stakeholder sessions and are still taking member comment and have a member survey out there. We did specifically reach out to SUFU. I do not know whether SUFU had any of their members or participants participate in those sessions, but we did actively reach out to them to ask them to help us recruit member participants.
Thank you. Though I also wanted to clarify one other point. While we were looking at claims volume for 2019, we looked at rates that were in effect for October of 2020 to match current rates to current rates in other states. So we were not looking at the 2019 rate. We were looking at the volume of claims for 2019, which I think is a fine but important distinction if there was a rate change. And as Michelle said, we're not recommending these rates, and in order to do that, obviously you would have to do quite a bit more cost-based research. This is just comparing to similar rates in other states that are providing a similar service as we could determine by looking at service description, provider requirements, the way the waiver is written and structured, and the waiver application, and all of those details to get as good of a picture as possible to match them.
Okay, thank you. Next up, I have Deb Smith.
Thank you for the opportunity to provide some feedback. My name is Deb Smith. I'm the Director of ID Services at OHI and also a member of the Maine Association of Community Service Providers. We provide supports to a number of different people, but specifically today I want to talk about the T2016 Home Support Per Diem program. I noted that it was not listed in the comparison report, unlike the T2017 and the T2021. I'm sorry. I'd also like to comment on the 5 states chosen for the comparison study. Even though Maine wasn't compared to the other states for the T2016 service, were the findings suggestive of qualities of the service did they set Maine apart from the other states? Is the population of individuals supported in the other states any different than the population of people supported in Maine? Are people of the same needs institutionalized in other states? New Hampshire and Vermont offer predominantly shared living services, so the cost should be lower than Maine, while North Carolina's rate structure is managed care. Both North Carolina and Connecticut institutions, and I assume that individuals with higher needs who have IDD and autism are served in institutional settings. Maine has a total of 17 ICF IDDs in the state. So most people with IDD and autism are served in the Section 21 and the 29 waiver programs. Maine currently supports approximately 5,400 people with IDD and autism in these programs across the state. Many are individuals who have more significant medical and behavioral needs than those served in similar programs in other states. Maine also has the largest aging population in the country. We provide supports to individuals who have significant medical complications and diseases, including cancers and dementia. We support people in home supports through their life cycle, and especially at the end of their life, to die peacefully at home. All of this is done without reimbursement for nursing services or a true medical add-on. When the medical add-on was created, it included reimbursement for additional support provided by any of the DSPs who are supporting people, like assisting people out of bed, supporting the use of ambulatory equipment, and training for our staff. Now it's set up so a provider of the service might be able to be reimbursed for a couple of hours or so if they need a nurse to come in and do something. The Section 21 waiver program also supports people with severe behavioral challenges in a home setting, in the community, requiring specialized training, supports, home and transportation modifications, additional overtime, and crisis services to be successful. There are no behavioral add-ons in the state and limited crisis hours unless you go over the 105% of the previously requested authorized hours for that person. Unfortunately, Maine's proposed crisis service system has not materialized, and it's not adequate to support the number of people in Maine who currently have behavioral challenges. Lastly, the comparison of the other 5 states doesn't consider the minimum wage issue. Both North Carolina and New Hampshire have a minimum wage of $7.25 an hour. Montana will be $8.75 in the beginning of the year, and Vermont has a minimum wage of $10.96. Connecticut is the only one that is somewhat comparable to Maine at $12 an hour. However, our minimum wage will be going up to $12.15 next month. And the Portland area is already at $15 an hour. I'd like to suggest that rates for the Section 21 home supports be set based on a person's needs, unlike what was done previously with the SIS assessment. The person-centered plan currently drives the system and the service for a person, so also let it drive the rate. A person's needs are individual, and a flat rate, and the rate should be individualized. Flat rates don't work. Let the planning team determine the need. In order to provide the best supports, we need a sustainable rate to support the person's needs. This could be done by evaluating specific areas for each person, like transportation. It varies statewide as well as by the individual. Medical needs. A true medical add-on that supports extra work and resources needed. Behavioral needs. A true behavioral add-on that supports the work and the resources needed, including emergency overtime when there is a crisis. Nursing services. Compensation for other comprehensive needs, such as those that are related to hospice care, when we provide that to people in their homes. The evaluation should also look at the minimum wage, taking into account that areas in Maine where the minimum wage are higher than other areas, cost of living, additional compliance requirements or add-ons, and a fair and reasonable allowance for administrative costs that recognize the cost of operation, including housing. I think that we'll find that many people won't require specific services that other people will and currently do need. Thank you for the opportunity to provide feedback.
Thank you, Deb. Next, I have Catherine Thibodeau.
Good morning. Thank you for letting me make some comments here today. I'm Catherine Thibodeau. I am the Executive Director of Independence Advocates of Maine. I also serve on MAXB's Board of Directors representing PNMI and ICF IDD Services. And just to sort of add an additional credential or whatever on that, I serve both of the national associations that serve ICF IID or represent ICF IID providers, both ANCOR and ACA, either on their steering committee or as a consultant. So I have a pretty fair knowledge of the ICF IID program across the country. And that is what I'm going to be speaking to primarily, Section 50 ICF IID. But at first, I wanted to just make a couple of clarifying and general comments. And I'm sure you guys all know this, but I feel like it needs to be said why providers of HCBS and basically any direct care service care so much about minimum wage, and why that is more important in our sectors than it is in many other sectors of Maine care. And that is because that is what drives our costs. That is primarily what the employees that support people with personal and health needs in Maine make minimum wage. And so when you're looking at a hospital rate, or you're looking at a dental rate, and you're looking at other rates, minimum wage does not come into factor as much. So I just want to make that point. The second point was I think I would be remiss if I didn't make this point. And I understand that the state of Maine is under a time crunch, but the expectation that providers will be able to provide meaningful feedback in 1 week's time amid a raging pandemic is challenging for me to accept. And that is, we are being asked to compare and contrast to 5 other states that we just found out about a week ago. And I want to point out, and it could be on my end, but when I signed up to speak, I did not get an Excel spreadsheet for Section 50 sent to me. So I had to wait until I think it was Sunday night when the full benchmarking report was released. And then my final, before my actual comments, sorry, you'll have to cut me off, but I will send them in. But my final point is I want to clarify what Becca was saying about the errors. So T2021 is listed as an $8.46 rate on the benchmarking report. That is not a current rate. That is not a rate that existed in October. So if that could be looked into. The other point that she was making was on the CY 2019 main claims data columns. And that data put in there for the DAHAB data and the data put in there for the supported employment data is the same data. So if we're just talking about the number of claims that happened in calendar year 2019, those services did not provide the exact same number of units statewide in that year. And I'm going to make an assumption here that the supported employment data is correct because it averages out to about 1,000 hours of service weekly statewide. And for us to provide communities, you guys have it at this day, but for us to provide community supports services, we know more than 1,000 units weekly statewide is provided of community support. So I just wanted to clarify that. And then now I'm going to speak a little bit to Section 50. There was what I think may be an error in that benchmarking. And it's because the fact that New Hampshire provides one federally certified ICF IID program in their state, and they support 20 individuals in that. And on the benchmarking report, its ICF providers show 79 providers with 5 different levels of care. And I did a little digging, but it looks like that might be maybe a nursing home, like a straight ICF level of care, not an ICF IID level of care. So I think it would be really important if you guys could take a look at that. And I also another sort of straight face is, I know the one ICF in New Hampshire provides very, very, needs to very, very high medical needs individuals. So the rate numbers that are listed there do not correlate with the service. I know that it's provided in that state. I know when people are going to speak about HCBS, they're going to point out Maine's sort of general IDD service sector delivery system as far as institutions versus non-institutions. And so in digging down that, I thought it might be helpful to just give you some compare and contrast information on that. Montana has no current ICF services. Vermont has one. You did point that out. But Connecticut has a system where they have 18 public institutions in their state serving 372 individuals, and then 67 private facilities serving another 378 individuals in their ICF program. And North Carolina has a very large utilization of the ICF program, approximately 40%, with 8 public institutions serving 1,059 individuals, with 330 private facilities serving 2,748 individuals. And to contrast that to Maine, we actually have 16 ICF IDs. Our bed and individual size is from the smallest ICF, which supports 5 individuals, to the largest ICF, which supports 17 individuals. That totals 180 individuals throughout the entire state of Maine, which is 3% of the utilization of the IDD services. So in simply in that, you know, you can, well, I'll give you some other statistics too, but simply in that you can see a very small portion of people are served in the the federally certified ICF program. When you start to look at who is being served across and compare and contrast between Connecticut, North Carolina, and Maine, and maybe a little information nationally, the ICF program is recertified every 9 to 15 months. And in that certification process, we need to provide a lot of specific data, and that data is compiled and available. And so to give just a couple of data points to explain maybe cost drivers to why the ICF program is a high outlier. When it comes to medical care plans for people who reside in the ICF program, 25% of the people nationally who reside in ICFs have a medical care plan, 31% in Connecticut, 14% in North Carolina, and 85% of the people in Maine have a medical care plan. When you look at supporting people with challenging behaviors, this is maybe where it gets really far into the weeds. But Maine does do a tremendous job through their behavior regulations and their expectations of person-centered planning teams and providers to support people with behavioral needs in a manner that upholds their human rights. And it would not be hard to understand that that costs more money. And some data points in Maine for the ICF program that show that is that medication, one of the reporting factors is we answer a question saying, how many people in your facility use medication to quote unquote control one's behavior? That's federal wording, that's not my wording. 50% of ICFs nationally do use medications to control one's behavior, 51% in Connecticut, 55% in North Carolina, and 3% in Maine. When it comes to physical restraints, 7% of ICFs nationally have individuals they use restraints on, 6% in Connecticut, 6% in North Carolina, 1% in Maine. And so I just really think it is in thinking about what the end result is to take this information gathered, and I assume you guys have, you're using a lot more information than you're sharing with us, but comparing the Medicaid codes in a silo and not really looking at the totality of the system when you're looking at system change and rate methodology change and rate changes is really doing a disservice to the people of Maine. And I just, my last plug, the people in Maine who get Maine Care and use Maine Care services are our neediest citizens. They're the least likely to be able to, certainly in the people that we support, are the least likely to self-advocate for themselves. And so I think it's really our duty as providers, as state employees, as contractors to remember that. And the decisions that we're making really do impact, lives of the people who reside here in Maine. And I am going to end my comments there. Thank you very much.
Okay, thank you. I just wanted to briefly remind people really quickly. I appreciate all of your comments, Catherine, but if we could try to keep it to 5 minutes so that everyone can speak, and I'll reopen it up at the end if we have more time. I also did want to mention related to ICFs, we actually didn't calculate a comparison, and we presented what was available in other states, but recognizing that ICFs are very complicated in how and who they serve. We didn't actually calculate a comparative percentage for that reason. So I absolutely recognize your comments that you made about ICFs, and I just wanted to put that disclaimer out there. So we can go ahead, Jillian, with whoever is next.
Okay, next up I've got Todd Goodwin.
Hi, good morning. I don't know how you have me. I don't think I raised my hand, but I may come back in a little bit. Thank you, though.
No problem. Okay. Next up, I've got Ray Nagel.
Hi, I'm Ray Nagel. I'm the Executive Director of Independence Association. I am in a non-practicing skilled nursing facility administrator and a non-practicing BC ABA. I've worked in Florida and Georgia in the systems, and I can speak to the systems in Florida and Georgia as they compare to Maine. First off, I want to echo the comments said by my predecessors. In particular, I thought Deb Smith, Catherine Thibodeau hit a lot of points with whom I agree. Again, I want to point out North Carolina's minimum wage is $7.25 and they have 5 state institutions. Connecticut's has 3 state institutions, and even Montana has 1. Montana did away with their state institutions, but brought back one that deals with people that have significant and challenging behaviors. It's important for everybody on the Zoom call here or the WebEx to understand that when we are being compared with the other states for how much money we spend on home and community-based services, that other states minimize the home and community-based service costs by using ICFMRs and state institutions, both of which are federal entitlement programs, and the state is not held liable for HCBS contributions. So it artificially inflates Maine's rates or the amount of money that we spend on home and community-based services. The other thing that I would like to talk about is provider tax. So I just Googled right now. I didn't look at all the states, but I just looked at the provider tax in Vermont. And I do not see them using a 6% provider tax on home and community-based services. Maine does. So when you look at our rate, you have to subtract 6% immediately, because when we get paid, we have to pay the state 6% provider taxes the next month. Another thing I'd like to elaborate a little bit about is Catherine pushed this point, and it's extremely valid. When I was in Florida and Georgia, a 3-bedroom home run under home and community-based services served 6 people. Okay. When I came to Maine, I had expected the same type of system, but I don't see any 6-bed homes that are originally with just three bedrooms. The human rights factor in Maine is significantly more emphasized than it is in other states. I can't speak to the other states that we are compared to, but I can speak to Florida and Georgia, where I worked for a number of years. The last thing I really wanted to emphasize, because most of my points were already pointed out, is in our community supports or rehabilitation. The state punishes agencies that are willing to admit individuals that have behavioral issues and individuals with physical disability limitations. Because it doesn't include transportation, the idea of getting a person out into the community that has significant physical handicaps, the cost is borne by the agency. The agency has to buy adaptive equipment and transportation equipment to be able to get that person out into the community. From what I've seen, the proposed amounts to serve one-on-one would not cover that cost. And there is no behavior incentive in the state of Maine. So the idea of trying to work with people that have significant behavioral challenges in any type of a rehabilitation program is not only dangerous to the individual, but it's dangerous to the staff member and the community at large if in fact we're abiding by the new community settings rules. I can't tell you how my agency, as well as others, have been impacted by the workers' comp costs that are associated with this. Other states, and I'm going to use Montana specifically, they have an institution that's designed for people with challenging behaviors. Those costs are borne by providers in Maine. Those costs are actually penalized at the 168-hour-a-week rule by 13%. If we exceed 168 hours for a person, the rate goes down % for every hour after that. Yet we're expected to bring people with these behavioral challenges out into the community. It doesn't make sense to me. So when you're looking at these states, I think we need to look at not only the minimum wages, but what are the daily practices? What type of human rights emphasis is maintained in those states? I would believe that North Carolina and Montana's human rights focus is far less than the New England states, to include Maine. And I also want to say that we should have at least had 30 days or so to be able to look at the comparative rates that you provided. And I was, on Thanksgiving trying to find these rates, and I thought that was a little caught me off guard. So that's all I have. Thank you.
Thank you, Ray. Next up, I've got Eric Mucky.
Hi, good morning, everybody. So first off, my name is Eric Mucky. I'm the business manager at Sweet Syrup here in Bangor, Maine. I want to thank everybody for the time this morning, and I wanted to say that the rate review is a fantastic start. But I did want to draw a couple of highlights to some of the economic environment that we're facing up here. The first one is that we have a very limited supply of DSPs, and that creates a significant amount of overtime as we're trying to, fill these spaces and just coming up short on our direct support professionals. We provide Section 21 agency home support. And so the wage, when a lot of folks are comparing the wages, I'm wondering if we're also thinking about the effect of overtime on that wage. It is a drastic difference. Another one is the assumed costs that are not typically thought of. One of the newest ones is the licensing requirements. As you guys know, we'll be instituting a new licensing regulation for the agency home support homes, and that has created a new batch of costs that were not accounted for in prior years. And it was voluntary, so now it's mandatory. Another thing is some of the assumed costs, such as food and supplies, that are not provided to our individuals through other means. Things like SNAP and some of the other benefits that are available to folks in the lower income brackets, which many of our clients and most of our clients are not adequate for covering their food needs. Some of our clients will have dietary needs and such that are not covered under other financial relief. One of them being over-the-counter medications and things. And they're small costs, but they do add up. As mentioned before, transportation, especially when it comes to the folks with physical disabilities, is very expensive as well. So I just wanted to kind of draw, I think most of my points have already been made by previous providers, but I wanted to talk a little bit about the economic environment and just sort of the high cost of low wages, as it were, with the increase in overtime that we face and turnover. And that's all I wanted to raise. Thank you.
Thank you, Eric. Next up, I have Heidi Leblanc.
Hi, my name is Heidi Leblanc. I am the Chief Operating Officer at Penquis. About 2 years ago, Penquis merged with Charlotte White Center, and we were able to support people within the community who have disabilities and need support in order to have a meaningful and impactful life. Charlotte White Support Services has been offering services for over 30 years, and we currently offer supports in homes, the community, shared living, and residential services under Section 21 and 29. I agree very much with points that have already been made and won't reiterate those. However, I do just want to speak a little bit to the wage issue and the assumptions made around wages and comparing different states. And the biggest thing for me is the why. Why do we want to look at those wages? And the people that we support are incredibly vulnerable, and through the course of their lives encounter dozens, hundreds of people who are providing for their personal care and their day-to-day well-being. And I think that looking at how do we propose rates that allow us to pay to attract quality direct care staff and pay wages that allow us to retain them, to allow some consistency and predictability for the people that we're supporting is critical as we go through this process. First of all, it will decrease our training costs and the associated administrative costs. It allows us to have a well-trained and skilled staff, which over the course of time will help us reduce our reliance on crisis services and ER services and hospital services, because we'll have a core of staff who know the client, understand their history, understand their patterns, and are committed to their success within that residential setting. I think agencies are being asked to do well above and beyond what the rates really reimburse. We have staff now who are working overtime. They are working with very, very challenging individuals with very unique needs. And they do that. They do that just wanting the best for that person within the community. I think if we could reduce turnover and reduce overtime, we could overall reduce costs within these programs. And I think we increase the quality of the support provided to the individuals we serve. And if we look at this from their perspective, from living in homes, having to move homes because agencies can no longer afford to provide the kind of service that they need, and they can't afford to provide it because they can't get staff, attract staff and train staff that will stay and commit to helping people achieve their goals. I think that's a piece that is missing, and I think we owe that to the people we serve as vulnerable Mainers. So I don't have anything else to add beyond that. Thank you very much for giving me the opportunity to express that, and I'm very interested to hear comments from my colleagues. Thank you.
Thank you, Heidi. Next up, I have Anne Marie Mayberry. Anne Marie, you should.
Hi, can you hear me?
I can.
Hi, okay, thank you, sorry. Good morning, my name is Anne Marie Mayberry, and I'm the Executive Director of GMS in Southern Maine, and I'll be speaking on Section 21 and 29. Limit my comments to that. Most of the things that I was going to say today have already been said, so I'll spare you some of that, but I wholeheartedly agree with my colleagues, Becca Emmons and Catherine Thibodeau and Ray Nagel and Deb Smith, who have so eloquently spoke on the points of having to, I'm sorry, on the work, on the points that we're talking about today for the payment methodologies. So I just wanted to, a couple of things that I want to raise that hasn't been raised yet is that back in 1981 with President Reagan, the HCBS program was born, and so he authorized that in order to reduce Medicaid spending. And so Maine in 1996 was one of the first states to completely abolish its institution, Pineland. And so many of the providers that are speaking today and that are on the call today started companies and small providers to serve the needs of people coming out of institutions so they could live in the community. And what that has meant to people is the ability to have choices and to have dreams and aspirations, to be able to be part of a community. And we can't do that without the assistance of a state government and federal government to help provide the appropriate rates needed to pay direct support professionals that are the conduit for people with disabilities to be able to live independently. In the state of Maine, we have, according to the Bureau of Labor Standards, CNA's average hourly rate is $13.72 an hour. We know that the state of Maine's reimbursement rate that's paid to providers is $11.21 an hour, which falls short of the $12.15 as of January 1st for Portland for Maine's minimum wage. And it falls extremely short of the $18 an hour that GMS and many agencies in Portland are currently paying because of the Question A referendum that was recently passed. So currently right now, GMS is paying the highest minimum wage in the country at $18 an hour for DSPs. So no, providers want, and I don't argue with the referendum question. I agree that minimum wage needs to increase. It needs to be a livable wage for our direct support professionals. However, we don't have a product that we can increase the value of or the price on to sell to the public. Our commodity, or if you will, is people being able to live in their community. And so we have to be able to pay our DSPs a living wage so they can provide these services for people to stay in the community. A living wage in Maine, according to the Department of Labor Standards, and I'm going to use a single person because I know that our agency is approximately 60 to 70% of single women that have children, and it's typical in this field that you'll find many people that are single and have children working as direct support professionals. And so the living wage for a single person with 2 children is $30 an hour. And that falls far from the $11.21 that we're reimbursed right now to pay a direct support professional. So, I know that that people with disabilities will always need support. We have an aging population that's already been raised. We're the oldest state in the country. Our reliance on direct support professionals will only grow. We are in a critical state now with not being able to attract a direct support professional to stay in the field with the rates that we're currently paying. A few other points that I'd like to make is that I agree with Catherine on the fact that a week is not enough time for us to do a deep dive into the 5 states that were chosen to compare to the state of Maine. Our agency, we've had 2 outbreaks of COVID. We're in the midst of a pandemic. And we've had a consumer pass away this week that we provide the hospice care to the end of life. So we're stretched thin, and we're not reimbursed for those services. We have 2 nurses that provide around-the-clock care for COVID and for hospice care. We have as I said, Maine is the largest, the oldest population. And so that also means that the people that have disabilities are being served in home and community-based services and not in nursing homes. So I just urge you to look at the components that make up a viable rate. People have mentioned transportation, the cost of living, add-ons for medical and behavioral, tying the rates to a minimum wage, and looking at the minimum of 180 beds of ICFs in the state of Maine, and most of our people are served in home and community services. So I know I probably have spoken a little bit longer than I should have, but I thank you for the opportunity, and I thank you for the opportunity to speak.
Thank you, Anne Marie. Next up, I have Joseph Kuhn.
Hi, good morning. Can you hear me okay?
Yes, we can.
Okay, thank you. I want to thank you for not only the opportunity to speak, but just the process that you're engaging in. I think it's truly needed. So I'm the director of an agency that supports folks in shared living and assisted living residences. I might be one of the folks that's been around maybe since the beginning, and that I've been doing this for about 35 years. What I find interesting is that so much has transpired that I genuinely suspect that a lot of folks don't understand how we got where we are. So, I hate to give a history on lecture, but all the way back in the beginning, rates were based on a true budget. We would sit down and we would explain, what our actual costs were for rent, heat, electric, phone, food, plowing and health insurance and retirement plans for employees, etc. Then, there started to be a series of cuts. I think one was a 10% cut. And back at that point, now we're going back 30 years. All our folks had, 401ks, vacations, sick time, holiday pay, the kinds of things that professionals get. Suddenly we were in desperation trying to figure out how to cut and shave. I hate to say it, but it drove a lot of folks out of the field, people who wanted to have real careers. And I would suggest that all of us, everyone participating in this conversation, first of all, we're all here. We could have chosen other paths, but obviously, something spoke to us that we wanted to be in the field of helping and caring. But you know what, folks, we also want to make a living and feel good about what we do. And, when suddenly we have to start implementing devices to try and shave things down at the same time that costs are increasing, we're truly compromised. So having said that, let me share that, after the true budget, which we all kind of decided, we were informed wasn't going to happen anymore. Although I would argue that if you're going to be in business, you should be based on business principles that involve, real cost, not what happened next. Because what happened next was a per diem based on the number of folks with everything included in the rate. So all of a sudden, having the lawn mowed or, plowing the roads or figuring out how to cover someone's workman's comp or health insurance, suddenly that was included in the rate. I've used this example before, but if the home down the street has a Toyota Corolla and we have a $50,000 wheelchair van, it's not really included in the rate. Suddenly things are getting kind of cloudy, and I hear the reference to transparent, but pretty much I think we were kind of left to have to try and cut and do whatever we had to do to try and stay in business. At some point in this process, and this is no offense to anyone here because none of you created this, but I started saying, my God, we're participating in voodoo economics here and an anti-business model. I don't want to be critical, but again, I'm not blaming anyone. None of you were involved, but I'm just trying to share what the history was. In that phase 2, there was a per diem based on the number of folks in a bed in a building. With any extraordinary needs, then there was a process that you had to go to validate and assure, for instance, intensively challenging behavioral people, et cetera. But then in the phase 3, we went to a per diem that was tied to staffing ratios. I would argue a lot of the other states don't have that. The problem with the staffing ratios is in the state of Maine, depending on what region you're in, you have some real labor shortages and challenges. And so my point is, suddenly what we find ourselves in is, not a true per diem. We'll get paid our per diem provided we hit our staffing ratio. So appreciate what that does. Suddenly we've got to do whatever it takes, which means paying a bunch of overtime to try and hit the staffing ratio so we don't get penalized for the per diem. To me, that's really not logical, and it drives up cost. I think it sounds like I'm being critical, but in the end, I'll try to give some helpful suggestions as well. But suffice to say that the penalty, because we can't find enough staff, drives up cost. There have been multiple minimum wage increases that I don't think are reflective of what's happening in other states. So to compare with other states, to me, doesn't entirely make sense, but I understand you have to have some frame of reference. But even within our state, there are regional differences in the labor market. Okay, folks down in Lewiston, Portland, they might have access to some wonderful folks that have embraced the American dream and have come here from away. Up in the mid-coast of Maine, we don't have that. We can put an ad in and have it run for 6 months without a person even applying. So we've got a real crisis when it comes to, if you would like some suggestions, one seems to me is that we should have a straight per diem that doesn't penalize, if someone doesn't meet the range. I mean, we're all trying to adequately staff our residences, but we're competing with, I hate to say it, Burger King and Walmart. And like I described, we've had to cut a lot of our the benefits that we would like to provide. I think we need to eliminate, these illogical structural handicaps. Staff ranges is one. I know in the current five-year new waiver, there's language about no overnight asleep.
Sir, if I could just ask you to wrap it up. We still have a few more people who would also like to speak, and I appreciate your comments, but if you could wrap them up in the next couple minutes, I'd appreciate it.
I will do my best. The whole idea of, the range is obviously one problem. Another is right now there's some language that's been inserted about no overnight asleep. The only way we have survived in our region is by, creating positions where people come for extended periods of time. They sleep, they're there, they're available around the clock. They're up multiple times a night. But this one is the death knell for us. I mean, and a few other agencies that I've talked to. I mean, we're going to have to get out of it because we simply will not have the finances or the personnel. I think we need, rather than more structural handicaps, I think we need some kind of enlightened, creative thinking about how to circumvent these issues. I think we need, we need to collaborate with folks. Back in the day, there were resource coordinators that actually went out and sat down and tried to create some new models. We are hampered with everything from, the pandemic to the current HCBS, infection control, the licensing mandate, increased workman's comp, increased health insurance, increased minimum wage. I'm really concerned about our ability to survive, quite honestly. But I'm hopeful that, with some creative ideas and again, doing away with some of the things that are illogical that accidentally create increased costs, that we may be able to turn the corner. So thank you.
Thank you, Joe. Next up, I have Pete Plummer.
Hi, thank you. I'll not talk about anything that's been talked about before, but I just want to say that I do agree with all of it, especially the per diem, the definition of per diem. Really, the per diem that Maine Care has is an hourly rate with a cap, with the potential of a penalty. It's really not a true per diem. So, but that aside, what I want to talk about is room and board. That's something that I know is not in the Maine Care benefit manual, but it paints the whole picture of care for the consumers that live in these homes or the residences. There's a ton of costs that providers that have these residential facilities have that are not part of the treatment rate. And so what we do is we bill the consumer for their Social Security income, and we leave them a certain amount of personal spending money, which is defined by the state of Maine in a big way. And so we have that net left, which isn't even come close to what it costs to provide a room and board for the consumers. So the state of Maine they offer a room and board subsidy, which is greatly appreciated. But the subsidy, it doesn't come near what the cost is to provide room and board supports to meet all the licensing requirements that a residential facility needs, all the food, and utilities, and on and on and on. And the way it's kind of calculated is they defer to HUD guidelines, but they don't really follow them to the degree that they should. They base it on a certain income that the consumers make, but they don't make an income. They just get their Social Security. So it's capped out at a rate that is faulty because they're not supporting, with the income that they're said to have. And that was 2 or 3 years ago. I don't know if that's still how they calculate room and board subsidy, but it's so understated. And so agencies are required to put up the difference. And we're struggling with the treatment rate already, then the room and board are the other side of the equation. So what I ask is, if you really want to look at the totality of care of these consumers, it goes well beyond Maine Care. And we need to look at the room and board subsidy also. And that's really all I want to say. But thank you so much for the opportunity.
Thank you, Pete. Next up, I have Heidi Manser. Heidi,
Hi, this is Heidi Manser. I'm the Executive Director for Uplift Incorporated. I want to echo and support the comments of some of my colleagues, Rebecca, Catherine, Deb, Anne Marie, particularly around the issues of minimum wage, looking at what other states provide for institutional care that we provide in community services, looking at what services are actually included in the rate. I also am very concerned about the length of time that was provided to stakeholders for analysis. 1 week is not enough. Finally, I understand that this isn't a current rate proposal. However, I worry that this incomplete and in some cases inaccurate data will be used to justify future rate proposals. I worry that the next round of proposals will be rushed, just like this feels, and won't allow for a deep dive that's needed to protect the services of Maine people. That's it. Thank you.
Thank you, Heidi. Next up, I have Jennifer Kinnelly.
Good morning, Kennelly. I work for Uplift Incorporated, and I first want to say thank you for allowing us to speak on this. I agree with a lot of the colleagues of mine that have spoken already, and I won't reiterate all of those points. I ask that we look at, if we're comparing just rates or the methodology behind the rates. I ask that as we dive into this to develop a better rate system, we compare apples to apples. And what I ask for is that we have a viable, sustainable rate. That is not what we have now. We need something that takes into account all of the points that have been brought up previous, and I hope we're able to work on that. Thank you.
Thank you, Jennifer. Next up, I have Scott Miller in the chat.
Yes, hi, thank you. And also thanks for allowing us to make and share comments during this time. So my name is Scott Miller, and I'm the director and founder of Creative Trails, which is the community support program of Support Solutions. We serve over 200 participants through 7 locations in 3 counties, and we have been around for over 15 years. I am inspired by the individuals we work with whose self-discovery, their independent skill building, skill set enhancement, community integration, and career exploration has grown tremendously over the years. There's a contemporary movement that is happening right now. I'm also humbled by the DSPs that pour their heart and soul for non-livable wages to make this happen. And I'm also proud to be working with my colleagues in Maine who are incredible leaders that have been pushing a contemporary movement and advocating for the IDD community. I want to just say that I 100% concur with what all my colleagues just said and stressed and shared and had questions about regarding community supports. I do want to emphasize around community supports, in order to meet the HCBS mandates coming up, the wage increases that are also going to be happening in the future, and then also the COVID crisis that we're currently in, which is killing our industry. In order for us to move towards a value-based system, which sounds like is the goal, which I think is a good idea, it is absolutely crucial that we have a rate to support this. Currently, the $6.53 quarter-hour unit will not be sufficient. I'm hopeful when we are starting to design the rates, so when you're starting to design the rates coming up, that there's going to be another stakeholder meeting. From the previous state studies that have taken place over the last 6 to 8 months that we saw through Burns and Associate, and also the renewal application, it's indicating a 21 to 40% decrease. And that's very scary. The methodologies following those rates would have negative consequences to the community support industry. There are misconceptions around setting values and ratio needs. If you plan to use those studies, I really hope that I have an opportunity to share input. So I just want to thank you for your time putting this, working on rates coming up, and I am very hopeful that we're going to have an opportunity in a timely fashion to work together. Because right now in the state of Maine, we are just struggling with the current rates and with the crisis of COVID that's in place. And I'm hopeful we can work together to get through this and to make the best service possibilities for the individuals that we support. It is so important because the more time and emphasis we spend on creating a rate that's sufficient, it's going to save us money in the future. So we got to keep a trend of going up with those rates and not down. The more we go down, it's going to create more devastation and it's going to create more financial costs in the future. So thank you again for allowing me to make comments.
Thank you, Scott. Next up, I have Cliff Wynn.
Yes, good morning. I'm Cliff Wynn, and I'm representing Coastal Opportunities. Firstly, I come on in full support of the very salient points that my colleagues have made to this point. I won't belabor them. I would also like to applaud the panel for recognizing the difficulty in comparing rates from state to state. I think that it's good to acknowledge that right up front. I would also, from a higher level view, just like to come on in support of the deeper dive proposition into each individual rate. I'm speaking primarily to 21, 29, and Section 50. However, I think it applies to any methodology that kind of starts with comparing states to states. When it comes to that, there's so many different socioeconomic factors at play. There's so many different delivery models, and there's so many different service populations that come into play. I find it very difficult to, although I understand that that's got to be a starting point. I just hope that eventually that's not the be all and end all, even after a deep dive. There's comparison of states. I feel an accurate rate study would look at and break down the actual cost of care needed to provide, the necessary supports within each individual rate, and essentially start with the individual needs and kind of work backwards toward what that cost would look like necessary to meet those individual needs. And I think in order to accurately compare states, if it can ever be done because of all the different nuances, you'd have to take almost that same level of intricate deep dive within the rates to come up with an accurate figure. So that being the case, again, I thank you for your time. I implore you to engage providers, as I know you will. It sounds like this is a first step, but in looking at the actual cost to provide the very particular individual needs of each person. And most of my other points have been made by my very articulate colleagues. So thank you for your time.
Thank you, Cliff. I'm not seeing any new hands. If you had your hand raised previously, if you could lower it, or if you have spoken previously and you have another comment, that lets me keep track of it a little better. I'm not seeing any new hands or anything in the chat, Julia.
Okay, thank you everyone for your comments. I just wanted to have a little bit of time. I just wanted to open it up if somebody would like to make an additional comment that has not already been made. I also would like to, if you could move to the next slide, make sure that you also, a reminder that you can also send us written comments at the rate setting eval at maine.gov, and we will look at those as well.
Okay, I have Catherine Thibodeau.
Hi, it's Catherine Thibodeau again. I won't be as long-winded. I wondered if I could ask a question. I know that it's not supposed to be a back and forth, but if we have time, maybe somebody could explain why T22016 was not included in the benchmarking, which is the agency home support. I know from our IDD provider sector that is the top pain point for providers, and an area where we've done a lot of advocacy. So I just didn't know if there's any information you could provide us on that.
Yes, the reason why it's included is simply because it would have been, we have to be able to provide a good match. As you can, the comments that you guys have brought up about minimum wage and other things already complicated what we could match. That is a per diem rate. It's structured in a way that is not structured similarly in the comparison states. And so to try to manufacture a code that would have looked similar would not have been reflective, and it just would not have been a good comparative match. So where there were services like that where we just couldn't reasonably reconstruct something similar in another state when it's just not operated that way, we just didn't include it, recognizing that no match would be better than representing a bad match or a bad comparison.
Okay, thank you.
Okay, thank you, Catherine. I've got Bridget McCabe.
Hi, this is Bridget McCabe. I'm an Assistant Associate Director at GMS. I work with Anne-Marie Berry, who already made some very succinct points. We support people on 21 and 29, and I concur with my colleagues in the multiple incredible comments made given the short amount of time we all had to dissect this. I wonder if Catherine's recent comment also applies to shared living. I didn't see shared living in the workbooks and wondered if you could speak to that as well.
It did apply also to shared living. We looked pretty extensively to try to find matches to provide some context. And I want to reiterate again that we're not suggesting that any of the rates included in here are the rates that should be selected. As everyone has said, a lot of these rates are based on the cost of providing business in that state, which is not the same across all states. So where there was something where it really just was not a reasonable match based on methodology and the way the state described and structured that service, we didn't include it.
Okay, next up I've got, actually I don't see any new hands.
Okay, great.
Oh, I think I might have missed one. Sorry. Tom Goodwin, did you want to speak or is your hand still up accidentally?
Oh, I'm so terribly sorry. I clearly know what I'm doing. But you've called on me twice now, so I will say something if I could.
Sure.
All right.
Absolutely.
So, I mean, like so many others have said, I agree with most, if not everything that has been stated already. I should say I'm the CEO with an organization called John F. Murphy Homes. We're based in Auburn, where we employ around 900 people across a pretty wide range of programs in the IDD world. And I'm one of the people that have not had an opportunity to even open a workbook. So I admit that I really, in terms of tying comments to any specific reference, I can't do that. Wasn't disinterest. It was, like so many others have mentioned, the height of the pandemic. We're going on 70 people diagnosed to date, and a couple of people that we're quite concerned with whether or not they're going to be with us much longer. So with that being said, I guess I would just say this. I really appeal. Well, first of all, thank you for this whole thing, but I appeal to the decision makers to recognize that we've been at this for years, and our system truly, you've heard it many times, but it's real, is in crisis. There is no plan B in our state. We're it, and we need help. So, please keep that in mind. I mean, numbers are hard things, but there's also the sort of moral aspect of this as well. So it's really important. If you look to us as an example, I mean, in terms of minimum wage and hiring workforce, all the comments people have made, I was reflecting on our situation. We employ about 500 DSPs. And, you know, at any given moment pre-pandemic, we'd have weekly training classes on the order of 20 plus people. When the pandemic hit, we limited that to 10 for public health reasons and guidance and all of that. And over the last month and a half, 2 months or so, we're lucky if we have 3. And we try to get feedback, and certainly there's pandemic and the risks that go into that and people nervous about it, but it clearly is pay. And in the home support realm, you know, one of the orienting questions was capacity. You know, it's inherent in what everybody has said already, but in our situation, I mean, we have 4 homes sitting empty. We just sold one. You know, that's taken away a placement for upwards of 16 people that are on our wait list right now. So, you know, I'm sure we're not unique in that regard, and it's all driven by everything we're talking about here. So hopefully something good will come of this process. Thank you for the opportunity.
Thank you, Todd. Next up, I've got Eric Mucky.
Yeah, hi. Just to speak again, I want to reiterate the context for the agency home supports. And by context, I mean that we're providing a functional household and all the costs that go along with it. I think most of the speakers were right in tying the rate to the labor cost, which is still, you know, even within home supports, agency home supports are primary cost driver. But there are so many other cost drivers involved. They've all more or less been brought up today. But I wonder if it would be more prudent to look at the overall cost of living of providing a household and all the costs associated with it. So many unpredictable costs, property damage. There's just so many other costs that are in excess of just the labor cost. So just wanted to reiterate that there is some uniqueness to the agency home support, and that perhaps looking at just the minimum wage is not adequate. Thank you.
Okay, thank you. I am not seeing any new hands or anything else in the chat.
Okay, great. Thank you, everyone. I just wanted to reiterate, if you would like to submit written comments, the email is up on the screen, the rate setting eval at maine.gov. Thank you very much for taking time out of your busy day to spend your morning with us. We truly appreciate it. And I hope that you have a good rest of your day. Thank you.
Thank you, everybody.